So this is the endocrine disorders lecture. Here's your learning objectives that come from your book chapter, a little bit more specific, but ultimately it's what the book chapter goes through. This slide is just a quick review of the endocrine system functions. So it's just a reminder of what you learned in anatomy and physiology. A couple of things that will be highlighted in this particular lecture that has to do with glands are the thyroid gland, the testes, and the pancreas. All of these are important. All of the glands are important, but they will be covered in other classes. So we're just covering the three glands, the thyroid, the testes, and the pancreas. It's important that you know what each gland does, okay, to the body. For example, the thyroid gland controls our basal metabolic rate. It keeps all of our cells moving along, doing what they're supposed to. And without the thyroid gland and without thyroid stimulating hormone, the body really comes to a standstill. So if someone has hypothyroidism, their body's at a standstill until we can supplement those hormones to kind of get that thyroid stimulating hormone and things going and the basal metabolic rate back on a normal track. So make sure that you know the slide and the functions of each one of these glands. The endocrine system secretes hormones that control numerous processes throughout the body. Age-related changes related to the endocrine system for the older adult are decreased bone remodeling, decreased lean muscle mass, increased adipose tissue, compromised skin integrity, impaired insulin signaling, and impaired immune function. The endocrine age-related changes, okay, that happen to the body, the first thing that we need to realize about this is that the endocrine system is very much responsible for the aging process. How things are connected and work together, and when they shut off at certain times really explains how people age biologically. The endocrine system is responsible for our vitality, for every part of metabolism, for reproduction, for temperature control, and there's many other things. So why does the endocrine system change as we age? Okay, so why does it change? One reason for this is that there is an evolutionary advantage to what changes are made to the system. Changes can be glucose is made more readily available for energy use. Changes may help the older adult conserve sodium and water so they don't become hypertensive. There's evolutionary advantages. Another big advantage to changes in the endocrine system is that most of the endocrine changes that take place lead to energy conservation. However, to make it easier to use energy, we have to go through these changes. Okay, so finally, there's some endocrine tissue that simply is not needed after a certain age. For example, with menopause, which is something that is universal for females in their 50s, reproduction just doesn't happen. So the ovaries just sort of stop working because they're not needed. So all of those things have to do with the evolutionary advantage. All of the processes that take place lead to energy conservation. And then also with the example of menopause, function of that particular gland may just no longer be needed. There are three main ways endocrine function changes. The first is hyposecretion. The other two are hypersecretion and hyporesponsiveness that we're going to talk about on the next couple slides. So we're going to discuss each one. Hyposecretion means that the gland fails to secrete enough hormone to meet the metabolic demand. And this could be because it can't recognize its trigger, or just it doesn't know to produce more hormone, or it has been atrophied, okay, or destroyed. Earlier in the semester, we discussed the thymus gland, for example, and how important that gland is for our T cells to mature. As we get older, or as the elderly or the older person ages, okay, their thymus gland turns from functional immune tissue basically to a blob of fat without any functional tissue. By about 30, okay, by about age 30, our T cells are really ready to go. So there's no need for the thymus gland anymore. So that's the reason for hyposecretions. Our glands just are no longer active because they're not needed any longer. Other examples here are listed on your slide. So the examples of the hormone, okay, their specific function, and then what happens as the older adult ages. Okay, these functions are either decreased, okay, or increased. Okay, for an example, calcitonin, right, on the slide. So calcitonin decreases as somebody ages. So that decreased calcium content makes the bones less dense. So patients are higher at risk for fractures. Osteoporosis is an abnormal change as aging, but bone density is not. So the second change that happens to our endocrine system is hypersecretion. And hypersecretion is the gland produces too much hormone. And this is not really understood real well as to why this happens. It may happen due to some genetic factors or possibly tumors within the gland that can cause hypersecretion. Both, okay, are not a normal part of aging. Both of those things are abnormal. But I have some examples of the hormone, and if the hormone is increased, and then what that does to the body. The third type of change is hyporesponsiveness. So hyporesponsiveness is the hormone has less effect on a target tissue. And this doesn't happen necessarily with the gland itself. It happens in the target tissue or whatever tissue that gland is supposed to be targeting, okay, for action. The receptor on that target tissue may be broken, or there aren't enough, or our hormones just don't have the action that they used to in order to bind and target that particular tissue. This happens with almost every hormone and every type of endocrine tissue we have. A good example is diabetes. Okay, it is a pathological state, but it explains our hyporesponsiveness to our tissue. And I just want to go back and do hyposecretion when we're talking about the actual hormones. Since it's hyposecretion, it decreases. It decreases the function or the production of those hormones, causing certain age-related changes, such as hypersecretion. If you notice here on the slide, the hormone is increased, and then I have the causes of what happens to the older adult as that hormone is increased. All right, so I want to talk about andropause. Now, back to the sexuality and menopause chapter, I did have one slide on andropause there because I think it was important to introduce it, but we're going to talk about andropause much more in depth now. Basically, andropause is late onset hypogonadism. It happens in men. It's not universal to all men. It happens to the majority, but some men may not have symptoms, or some men might get really affected by it. It's really a new condition. We're not quite sure what the risk factors are, or what causes it, or how to prevent it. But we do know that it is an age-related thing that happens to testosterone. So the first thing is that men have increased anti-testosterone antibody production. Men have these antibodies that seek out and destroy testosterone. And this happens more and more as a man ages. There's other changes with hyposecretion, also with andropause. The testes secrete Leydig cells, which decrease with aging, and then luteinizing hormone from these Leydig cells also hyposecrete. So luteinizing cells, if you remember back to your pathophysiology, are the ones that stimulate the Leydig cells to produce testosterone. So if we don't have enough luteinizing hormone, it interrupts that whole chain. Okay, that Leydig cells and then the production of testosterone. So all of these things put together lead to a decreased testosterone level. And all of these at some degree are influenced by genetics, but there's also some risk factors that can determine, okay, the development of andropause. So the risk factors that we know of are listed here on your slide. The older a man gets, the more likely they are to develop andropause. Obesity can also be a major risk factor, and it's really unclear of how obesity works. But is it that the obesity, or if someone is obese, they produce more testosterone or have more issues with testosterone? Or is it because fatty tissue secretes more estrogen? Okay, so it's not clear if there's more estrogen because of more fat tissue to throw that balance between the estrogen and the testosterone level off. Okay, the debate is still out on that. Glucocorticoid use also has been pretty well studied as a risk factor. The big complications with andropause are listed here on your slide. A sexual dysfunction among these six is the only indication that we would use to give a testosterone supplement. Okay, so we don't know if testosterone fixes any of the other six, okay, complications of andropause, but we do know that it fixes the sexual dysfunction one. So, of any of these complications, we would only use a testosterone supplement for severe sexual dysfunction. Here are the signs and symptoms. They are broken down into three categories for you. So, with the sexual dysfunction, there's decreased libido, fewer morning erections, and erectile dysfunction. These are critical features of andropause in the sexual category, and this is what would lead to that testosterone supplementation. The physical ones have been researched quite a bit, okay, and they're listed there on the slides for you. Men with andropause do have hot flashes, okay, and they also tend to have more fractures. Those are two things also in the physical signs and symptoms that have been well studied. As for psychological, you can read those here: loss of energy, sadness, fatigue, and irritability. Diagnostic testing for andropause, we focus on serum testosterone levels, which of course would be low. We're also going to look for complications, for example, looking at things like osteoporosis. So we might do a DEXA scan. We want to look at the BMI and the body fat percentage. We can also do labs to rule out causes of some of the other symptoms, like the fatigue and things with symptoms from the previous slide. We can look at a CBC with a differential to see maybe if it's anemia causing that or the patient has an infection. A CMP, a magnesium level, low thyroid symptoms will also look like andropause. And then we could also get a vitamin B12 to rule out other causes of the symptom. Testosterone replacement, okay, is the medical intervention, but it should only be used in men who have severe sexual symptoms, okay, and also a low risk profile for prostate cancer, okay, and that's what the research is saying right now. Excuse me. So we only give testosterone replacements for andropause if the man has severe sexual symptoms and is low risk for prostate cancer. It's not that the other symptoms can't trigger treatment, but we just haven't really studied or researched, and the guidelines right now just say testosterone replacement for these two categories. So testosterone is a Schedule 3 drug, so it's in the same category as Vicodin or Norco. A big issue is that there's a lot of social connotation okay, with testosterone replacement and andropause because of like the manliness, okay, of this illness. But there's also big issues with diversion and overuse of testosterone. Diversion has to do more with maybe the man will sell their supplements or people will steal them. Overuse has to do with people thinking that, one patch is good. If I put two patches on, it's going to be even better. Okay, so sometimes the older adult can overdose on testosterone. If you are the provider or the nurse and are concerned about either one of these issues, a testosterone level can be drawn and checked to see how much testosterone is actually in the system. If there's too much, it might be overused. If there's too little, then maybe they were stolen or the testosterone replacements were sold. There are several major warnings of testosterone, and that's why many people don't take testosterone replacement or why many providers may not prescribe it. It can cause infertility. So if a male is actively wanting to conceive, it's not a good idea to take a testosterone supplement. Take after the male's had children or does not want any more children. It can also worsen hypertension significantly, so much so that the male may need to go to the ED. It can also worsen heart failure and benign prostatic hypertrophy. It increases the risk for other things that are listed on your slide as well. And with the sodium and water retention, when we talk about hypertension, remember that sodium and water retention can lead to hypertension as well. Okay, so it can worsen hypertension and then also increase risks for things that can increase hypertension. One of the most important warnings that we talk about with testosterone replacement is that women and children should not come into contact with any testosterone supplement. So if a man puts on a gel, we need to make sure that gel's dried and covered by a shirt. If a woman or a child touches the area, they could absorb it into their skin. The most preferred formulations is IM because it's hard to steal, okay, an IM injection or to sell it, okay, if it's in the muscle. Other common formulations are topical, but again, topical can be easy to divert. And this is the main way that they are usually prescribed, though, is the topical. There's also a pump foam androgel, which can be ordered, and it's dosed by how many pumps the male would take. The androderm is a patch that the male can put on at bedtime. The other forms of testosterone supplementation is not used very often anymore. There is an oral form that is brand new. It's Janpenzo, but most people still continue to use the topical or the patch. And as I said, the IM is the most divertible medication because you can't take it out of the muscle. Nursing interventions are really to monitor symptoms, to monitor sexual function. It should be better after the man starts testosterone replacement. We also want to monitor those serum testosterone levels. We want to get a lipid panel also because of the higher risk for cardiovascular disease. And look at the prostate, look at prostate symptoms, okay, as well, such as urine dribbling, hesitancy with urine, and frequency of urine. Testosterone should be given as ordered. And as nurses, we have to know how testosterone supplementation is used. And it's not used very often. So we might need to look it up to make sure that we know the side effects and we can really explain to our patients how to use this medication and how to prevent complications, keep it out of reach, for women and children. The correct site you need to apply the medication to the correct site. When these first came out, it was thought that if we put them on the scrotum or on the inner thigh, then the male would get more of the effects of the testosterone. However, with research, we found that We shouldn't be doing that because there was more of an effect of the prostate if we applied the creams, the gels, and the patches to the scrotum area. So instead, we now make sure that we put the gels and the patches on the upper parts of the body. As healthcare providers, we should always wear gloves when we're applying any type of hormone supplement because it can leak into our hands. We want to make sure that we count the patches since it is a scheduled drug. And also, we want to provide emotional support because andropause can be very hard on people and hard on families. Right, so this is what topical formulations look like. So we have the patch, the androderm patch on the left, and then the foam pump, the androgel on the right. Think what you might teach our patients is how to use the supplement correctly. Okay, it's important to keep away from women and children. We talked about that. Sterilization and symptoms also can be very severe. Make sure that they don't, we talk about, medication diversion, so not to sell or give away their testosterone. Make sure it's locked up to prevent people from stealing it as well. Only take what's ordered as well. Okay, so only take, the amount that's ordered, not double your dose or anything. And then know and monitor for the things on the slide because the risk of cardiovascular disease or exacerbations of cardiovascular risk is one of the side effects of the medication. So we need to make sure that the male monitors themselves, okay, for these symptoms. Oh, also don't mistake the especially like the hand soap or the pump gel form for actual hand soap or different lotions and stuff. So again, make sure that we're keeping and we're instructing the male to keep these things away from women and children. All right, so let's move on to hypothyroidism. So this is a diagram of how hypothyroidism happens. Basically, the thyroid gland becomes hyporesponsive. So the thyroid gland is not getting a message from the pituitary gland that they need to pump out more thyroid hormone. Unfortunately, the thyroid gland is not getting the message or it's not processing it correctly. The pituitary gland pumps out more and more than thyroid stimulating hormone because the thyroid isn't doing its job. And there's no way to really turn this off until we replace the thyroid hormone with supplementation. Okay. That TSH will just keep being produced by the pituitary gland. And then the thyroid gland really isn't getting the message of all of this production of TSH. So what happens with hypothyroidism is that the thyroid just isn't producing thyroid hormone, and it's not enough to meet the metabolic demands of the body. Okay, there's not enough to keep those cells working. They're not going to. So if there's not enough for the cells to keep working, those cells in the body are just going to want to shut down and then do nothing at all. Thyroid hormone is the main key that gets our cells woken up and ready to work. Okay, so the pituitary gland pumps out more and more TSH to cause the thyroid gland to secrete hormones, but the thyroid gland isn't getting the message. Okay, and the only way to stop that loop, okay, again, is to give supplementation. Basically thyroid hormone just isn't getting to where it needs to go, or it's not producing enough thyroid hormone. Okay, so basically the thyroid just isn't producing enough, not doing its job. It's simply not producing enough thyroid hormone to meet the metabolic demand. Okay, so it can't keep cells working. Physiologically, this causes issues with cell regeneration and cell growth. What happens is decreased cell regeneration. So if the patient gets a cut or a scrape, it's going to take longer time to regenerate that tissue. That tissue may fill in with scar tissue instead. If a patient has a pressure injury, okay, or another type of injury, it's going to take a long time to heal those because that thyroid isn't secreting that hormone to meet the metabolic demands of the body. Nerve conduction can also be really slow when with hypothyroidism. So if they don't take their supplement, okay, their muscle contraction will be a lot slower. The main cause of hypothyroidism in older adults is an autoimmune disease called Hashimoto's thyroidosis. Okay, Hashimoto's thyroiditis. Thyroiditis. And that's the immune system fails to recognize the older adult's own thyroid tissue and it starts to degrade it. So the thyroid can't produce any thyroid hormone. Okay, another major cause, okay, of hypothyroidism is iodine deficiency. Risk factors for hypothyroidism, the two biggest are being female, and especially females over age 60. Okay, females over age 60 have 2.5 times the risk of hypothyroidism compared to men, and especially if those females have had children. Having another known autoimmune disease puts the older adult at higher risk of Hashimoto's. Okay, so having these things also on the slide can put the older adults at risk for autoimmune disorders. Any type of history of neck eradication, so radiation to the neck, causes damage to the thyroid and can knock it out or cause it not to work. Any neck cancers may be an example of a disease where someone might have had radiation. So lots of signs and symptoms of hypothyroidism. Okay, basically everything slows down. Okay, so I have all kinds of things listed here related to the different body systems, the signs and symptoms in that particular body system. But basically, everything just slows down. When the thyroid isn't producing hormones, okay, it slows the heart rate down. The older adult may need intensive care because of that bradycardia could be so severe. We also want to monitor for dryness. The hair often becomes coarse, brittle, straw-like with patchy hair loss. And here's some more signs and symptoms related to different body systems. Again, everything just kind of slows down. People with hypothyroidism also have very recognizable facial features. They may have a dull facial expression. They have these periorbital edema under their eyes. A lot of times the bags under their eyes really overlap the cheek, okay? And that can be seen as very consistent with hypothyroidism. Almost like sometimes when you see patients with these, it's almost like they have big like water blisters underneath their eyes. Also, NCLEX really likes to ask questions about signs and symptoms of hypothyroidism, about the cold intolerance, the weight gain, the tiredness, also the patchy, brittle hair. So commit those symptoms, especially to memory. So here's an example of those facial features or the typical signs of somebody with hypothyroidism. All right, so the picture, that compares on the left of the screen here. You see the first lady there. She looks like she has kind of a grouchy face. You can see that periorbital edema. her whole face looks kind of sagging. She just looks tired. After we treat this patient with thyroid supplementation, her edema is gone. Her face looks a lot more expressive, although she still looks a little grouchy. Okay, it's not as much sagging. She just looks better. Okay, so that's what thyroid supplementation can do. The other picture here is characteristic of that patchy hair loss, which is very, very common with hypothyroidism. So with these pictures, again, symptoms of hypothyroidism is goiters, so goiters in the neck. And these will be very recognizable if someone with hypothyroidism. Many people have goiters, okay, but they really don't get large. Some people have just thick necks, so they look like they have a goiter. We call those hidden goiters. But you can see by these pictures, for example, the first one on the left, the base of the neck might have a little bit of an ouching. Okay, but in the second picture, you can see really both lobes of the thyroid gland. Okay, and there's really no reason to let a goiter this big happen. Okay, other symptoms are probably exhibiting too, and this patient just really needs to get their thyroid checked and have treatment. Okay, there's no reason to let hypothyroidism go along that long to cause this big of a goiter. Another sign that people might present with is myxedema coma. Now, this is life-threatening hypothyroidism. Everything slows down so much that the body basically shuts down. There's no metabolism going on at all. Neurologically, these patients are unresponsive. Okay, they have severe bradycardia, severe hypotension. They're in respiratory failure. Their temperature is very low, okay, usually less than 36 degrees Celsius, and they're hypoglycemic. Okay, and that low temperature is really a key finding. People with hypothyroidism tend to have low temperatures anyway, but then if the temp gets really low, it's really indicative of this myxedema coma. To diagnose this, we check the TSH and the T4. And if both of those are low, we give large doses of levothyroxine. The focus is also is on IV fluids, okay, to get those pressures up. We also give vasopressors to support blood pressure. We may need to start them on BiPAP or intubate, remember, because their whole body is just shutting down. After intubation, a lot of times they will need mechanical ventilation. One of the main causes of myxedema coma is someone who didn't know that they had hypothyroidism, was never on any supplementations, or maybe were not taking their supplements for many reasons. They couldn't afford it, they didn't understand, they didn't think it was important. So as nurses, we need to find out the cause, okay, of the myxedema coma, and make sure that we educate the older adult and treat it, educate, and prevent it. Diagnose, okay, I said already that we get a TSH level. If the TSH level is high, the only reason that it would be high is because of hypothyroidism. And if you remember back to the pathophysiology we talked about, it's high because the pituitary gland pumps out tons and tons and tons of TSH, okay, to wake up the thyroid gland, but it just can't do it. So it can't wake up that thyroid gland, so that thyroid gland starts producing hormone. If so the T4 will also be low. Okay, so the T4 will be low because that's what is secreted by the actual thyroid gland. So we also look at some other blood work that could cause symptoms, okay, of hypothyroidism, like anemia. So we want to look for the hemoglobin, a basic metabolic panel to check the sugars, a hemoglobin A1C again to check for diabetes. So these diagnostic tests are for hypothyroidism, not myxedema coma. So treatment. Treatment consists of lifelong supplementation with Synthroid. The formulation that the patient is on, the manufacturer that makes the drugs, should always be that medication shouldn't be changed. So we shouldn't use Synthroid pills from manufacturer to manufacturer. Okay, we need to stick with the same manufacturer, the same genetic pill always, because the pills actually have a lot of different ingredients in them and they can work differently. So if the patient goes from one manufacturer to another, they could really end up with a different response to the Synthroid, okay, or the levothyroxine. So it's important that we explain to patients whatever levothyroxine you start taking, make sure you stick with that manufacturer, you stick with that exact medication. Don't switch drug companies, don't switch manufacturers, don't allow your pharmacy to switch those for you. I have the usual dose here on your screen. It's dosed in micrograms, so just keep that in mind. It must be given on an empty stomach for absorption, and it must be given first thing in the morning, okay, before the patient gets up and moving, because remember, it's going to kind of wake all those body cells up. The side effects, okay, if the person takes it late in the day, could be insomnia, okay, or a thyroid storm if they take too much of the medication. And I'm going to talk about thyroid storm on the next slide. So thyroid storm is also a life-threatening excess of thyroid hormone. Myxedema coma, okay, it was a life-threatening, but from too little thyroid hormone. Okay, this is an excess of thyroid hormone. Okay, so it's at the other end of the spectrum. Signs and symptoms, okay, of thyroid storm are completely opposite of myxedema coma. All right, so the signs include the body's really speeding up. They're tremor, they have angina because they have an increased metabolic demand, the blood pressure is high, they have tachycardia, dyspnea, a lot of times confusion and sweating as well. Because the cells are being told to work, but they only have so much oxygen available, and the patient only has a certain amount of oxygen in the body. So these patients, do often have angina, shortness of breath, and confusion because their cells are really working like crazy because we have too much thyroid hormone on board. Also, patients here will have a high temperature, okay, 102 or 103, okay, because of this extra work. Everything is revved up, everything is set up. Treatment, okay, for thyroid storm is to hold the medication or give a medication that blocks or destroys thyroid hormone itself. So PTU is one that we give, okay, it's the main one that we give. The other one listed here, the anti-thyroid medications, is an alternative. We can help also decrease the temperature, okay, that high temperature, by giving the patient a room temperature bath. We need to make sure that we monitor the heart rate, usually with telemetry. We may want to give some beta blockers to control the heart rate and also the oxygen demand. We want to provide oxygen supplementation, okay, as well. And these patients also might need BiPAP, intubation, and then mechanical ventilation. Nursing interventions, okay, if we continue to go through the monitor, perform, and teach, just like we've been doing for these illnesses. We want to monitor energy levels because these patients with hypothyroidism will get tired very easily. We need to make sure that they monitor their TSH yearly, monitor any medications that they're taking along with their weight. if they start gaining weight, it might mean that they don't have enough of the thyroid hormone on board. Also could mean that their cardiac risk factors will go up, okay, as their BMI goes up. Okay, and then also monitor for depression, cognitive status, and then of both of those life-threatening conditions. We want to provide emergency care at either end of that thyroid spectrum. Okay, so either the myxedema coma or the thyroid storm. We want to make sure that we monitor for some of the signs and symptoms. All right, and allow for rest periods because these patients will get very wore out very quickly. We want to educate or give those medications as they're ordered. We want to promote a positive self-image. A lot of the signs and symptoms of hypothyroidism are cosmetic. Remember back to that picture, all right, that we showed. So anything that we can do to promote that positive self-image, like styling their hair, helping put on makeup. It's recommended from the American Thyroid Association that we should be screening women every 5 years after they reach the age 50, okay, because that's when hypothyroidism is most common. And what we're looking for in the screening is if we should start a thyroid supplement. All right, so teaching are those things, you know, on the slide, the emergency signs and symptoms, keep a healthy weight, don't miss any of your levothyroxine doses. All right, so let's move on to complications of diabetes. So most of the time we hear about diabetes being a risk factor for stroke and for MI, and those things are macrovascular complications, or complications of those large vessels. So what we're going to talk about today is the things that happen to the microvasculature or the capillaries. And these are important because they take a long time to develop, but they have significant impact on the quality of life for older adults. We're going to talk about the kidneys and neurons today. Damage to the microvasculature of the retina also happens, but we'll talk about that in another lecture. So what happens, okay, with these microvascular changes or complications is when the capillaries are chronically exposed to high amounts of blood sugar, it causes microscopic damage to the inner linings of the capillaries. And whenever you have that small microscopic areas of damage, you get an inflammatory process that's always brewing, it's always cooking within that particular area of damage. With the inflammatory process, we have a big rush of cytokines. If you remember back to some of our previous lectures, we have a big rush of cytokines and interleukins, and the vessel starts to change structure and function. One of the big structural changes that happens is the vessels develop microaneurysms. And these aneurysms will burst and will cause issues with local tissue ischemia, or the blood might have issues with blood inflammation that can also further cause damage to the vessel. So overall, the tissues, okay, in this microvasculature become ischemic and they lose function. This usually happens over decades, but it can really depend on how well the sugar is under control. If a patient's had poor glucose management, these changes can happen much quicker. So it's a really good thing to keep in mind and keep reminding our patients that the more control they have on these vessels, the slower the microvascular changes will be. Okay, if their blood sugars are out of control, their sugars, you know, are all over the place, the quicker the damage to the microvasculature is going. All right, so let's talk about diabetic nephropathy, and this is damage to the kidney. So it's that capillary level inflammatory response that's happening in the glomeruli. So in the picture here, kind of at the bottom, okay, of the screen here, There's two glomerular capsules. And the main function of these capsules is to filter the waste from the blood. Okay, so the only thing the glomerulus can filter out is waste. Okay, and the first picture is a healthy glomerulus. You can see the light blue-green tube that's almost split into two. This is like indicative of the renal arteries. The red blob in the middle is the glomerulus. Okay, and the glomerulus is where the blood comes in and the stuff gets filtered out of the blood. It goes into the urine collecting ducts, then ultimately gets excreted from the body. Without the connection, okay, between like the glomerulus, okay, all those little things, and the urine collecting duct, okay, without that connection between those, that filtering process can't happen, and the urine does not concentrate. So as the blood's being brought into the glomerulus, it's dropping off its waste and it's coming out the bottom end. Okay, and that blood is then going back into the venous circulation after all of the wastes have been excreted. Okay, so that's what happens in a healthy glomerulus. Okay, so healthy urine, okay, is great, right? The only thing that the glomerulus can filter out waste-wise, okay, is water and electrolytes, okay? And that's really important because those molecules are very small and they can only fit, they're the only molecules that can fit through the glomerular capsule to help concentrate the urine, filter those wastes out of the blood. Okay. So in the other picture, in the diabetic kidney, the inflammation, the microvascular inflammation, causes that glomerular capsule to kind of rip apart. So instead of being like tiny little stuff getting through and getting filtered out, the damaged glomerulus can let out huge protein. So the patient can basically dump out protein into their urine. And this can cause some significant problems with circulatory volume. As the proteins that are leaking out, so is the water. Okay, the water is going to follow the protein, so it's going to filter out even more water. So now patients may lose bunches and bunches of water, not just kind of that waste and that water and that electrolyte, but loses bunches and bunches of water volume and a bunch of protein. So now the blood vessels don't have any protein. And when your vessels don't have enough protein in them, this volume goes into the interstitial fluid and the patient ends up with edema. In the kidney of a diabetic person, the kidney just cannot concentrate or make urine. Initially, the patient may get a ton of urine output. Then they transition to maybe oliguria or very little urine output. And the urine often also is very, very foamy. The patient may have peripheral edema due to this low serum protein, and symptoms of chronic kidney disease start to happen, okay, like itching, uremia, confusion, and a bronze skin color. All right, so here's a picture of that foamy urine. Okay, so foamy urine is a sign, all right, that the kidneys, that glomerulus is starting to damage. Okay, so here's a picture of foamy urine. It's not kind of a bubble here and there. It's more of that dense foam, like hard foam, okay, that the patient is urinating. As for, so that's one sign, okay. As for diagnostic testing, okay, for diabetic nephroscopy, all right, is a basic metabolic panel. So we want to monitor renal functions. We also want to monitor for glucose. A 24-hour urine is done, and what that looks for is the total amount of protein that the patient urinates in 24 hours. And then this is compared to the microalbumin, and the ratio tells us whether or not they have diabetic nephropathy, okay, or some other type of kidney problem. So as for interventions, the focus really is on preventing progression of that, the kidney damage. The patients must keep their sugars under control. If they don't, they could risk losing kidney function. Okay. ACEs and ARBs also help preserve that renal blood flow, so they are protective of the kidneys. Okay, with patients with diabetes. So oftentimes you'll see a diabetic patient on an ACE or an ARB. Once the nephropathy is started, it can't be reversed. Okay, so all we can do is slow down the process. So we might do things like really educating on how to control blood sugar, having a nephrology consult. Okay, the patients may need hemodialysis or a kidney transplant. We want to also make sure that we monitor and we instruct patients to keep their eyes on their sugar, to make sure that they know how much urine output they should have, okay, and the characteristics of that, and then what urine might look like if they're having these different renal changes. We nursing interventions also, we might need to do a 24-hour urine collection. And we need to collect every single drop of urine for 24 hours. We cannot waste even a drop. Blood sugar should also be kept between 80 and 120. Okay, and this can be done through diet, exercise, and medications. A lot of drugs are hard on the kidneys, like contrast dye. Metformin is also a big one that's hard on the kidneys, and also antibiotics such as vancomycin and NSAIDs. So the patient needs to know what medications are nephrotoxic and not take those. Emotional support is needed if the patient is transitioning to dialysis. And we also want to make sure that we teach the patients to understand the line of progression. If we don't control our blood sugars and these kinds of things start happening, this is what could occur. All right, so another change that happens to this microvasculature is diabetic neuropathy. So make sure for testing purposes, okay, that you know the difference between nephropathy, okay, and neuropathy, okay? Nephropathy and neuropathy, okay? One has to do with the kidneys, one has to do with the nerves. So make sure that you carefully read questions that might be on the exam. Okay, so the same microvascular changes that happen in the kidneys can also happen around the nerves. Okay, the nerve will lose patches of their axons over time, and we get messages then that aren't sent along that axon. Maybe they're incomplete or they never really happen. So the patient often feels like a buzzing, burning, itching sensations in their nerves. Okay, because those nerves are just so fired up and they don't really feel right. There's just kind of this weird static going on, or this weird static feeling from their nerves because those axons lose patches over time. Those messages just aren't getting sent along that axon for complete sensation experience, or they never happen at all. So over time, the sensory information gets lost. Okay, the conduction of these sensations gets lost altogether, and the tissue becomes numb. Once the numbness kicks in the motor neurons don't know really what to do because they have no sensory information coming into them. Okay, nothing's getting to the spine to tell these motor neurons what to do. So, along with the incomplete messages, with the buzzing, the burning, the itching, we get this numbness along with muscle atrophy and disuse. Diabetic neuropathy can challenge mobility. So on the slide here is also the signs and symptoms. Okay, diabetic neuropathy always starts in the feet and then marches up the leg. Rarely does it start in fingertips. Usually when the patient, when these sensations, okay, or um, this happens at about mid shin, then the patient starts to get symptoms in their arm. Okay. Patients often can't feel where they're walking. They can't feel where they're stepping, or they could step on something and don't realize that they've stepped on something. The peripheral autonomic nerves also become affected. So things like changes in blood pressure start to occur. Okay, the patient might get kind of a wacky heart rate. It might go up and down. Bowel and bladder dysfunction might also occur as this diabetic neuropathy progresses. Okay, constipation might alternate with diarrhea. To diagnose diabetic neuropathy, we do sensory testing on the feet. And what this person is doing in this picture is the monofilament test. It's basically a pinprick on the bottom of your foot. There are 9 spots on the bottom of your foot, the big toe, there's spots on the ball of your foot, midfoot, and then on the heel. If there's any loss of sensation, that needs to be documented along with some of the other tests that we're going to talk about, or that are on the slide here. Electro myography was done, but not as much anymore. We really use this monofilament test as pretty diagnostic. And there's a lot of exact tension on this little monofilament, okay, and that pinprick on the bottom of the foot. So it is really an objective test. As for medical interventions, we want to focus on blood sugar control and protecting the feet from injury. We want to make sure that we're really keeping those feet protected and make sure we instruct the older adult to really keep them protected. We want to make sure that the patient doesn't develop diabetic ulcers. Okay, and there's going to be a couple pictures on the next slides about this. We want to give medications for any neuropathic pain, for that burning, that buzzing in the legs. Amitriptyline or Neuron are usually the ones that are given, and they work very well. Amitriptyline tends to be easier on the kidneys. Lyrica is an alternative to Neurontin. It's less hard on the kidneys, okay, than Neurontin is, but it's much more expensive. The Lyrica is much more expensive. Neurontin, as I said, can affect the kidney. Cymbalta is an SSRI medication that we can use. If the patient does complain of a lot of burning, also, we can give a lidocaine or a capsaicin patch to help almost distract that nerve impulse from the. So we want to make sure that we offload the pressure of the foot, and that is very important because these certain things can happen with diabetic neuropathy. The picture on the left is Charcot foot deformity, and it's very common with diabetic neuropathy. If this goes on for a long time, the patients really lose sensation. They can't tell where their foot is. They can't tell if their foot is hurt at all. We also don't have a patient with the Charcot foot also does not have sensory motor coordination. So they end up losing that arch. And it causes metatarsals to have fractures. They inflammate, and then soft tissue damage happens in Charcot foot. We can also call this rocker bottom foot. These patients can't walk. We need to make sure that they're safe, that their feet are always protected. So we want to make sure that we offload this pressure always. On the right, this is an example of a diabetic foot ulcer. Diabetic foot ulcers are always on the midfoot. Okay, this one may have been caused from a Charcot deformity. If you notice that rim around the ulcer looks very discolored, this is a callus. Okay, all foot ulcers due to diabetic neuropathy start from calluses. Eventually that callus puts pressure on the bottom of the foot, okay, because it's almost like a hard rock there. Okay, so it puts pressure on the tissues of the foot, and this ulcer develops. Diabetic foot ulcers are very hard to treat. The blood flow, because of the neuropathy and those microvascular as well as microvascular changes that happen, really diminish the blood flow. And if the patient does not stay off of their feet, this diabetic ulcer can get infected with many different organisms. So ways to offload pressure are here on the slide. On the left is a removable cast walker. The patient can remove this as needed. The middle one is a Scotch cast boot, okay, which is another option. And then the one on the right is a sandal cast. So this is like a removable cast. It's just on the foot. The person here in this picture, you also notice, is missing their toes. Okay. And a lot of times diabetics will have of their toes amputated to prevent osteomyelitis from developing. Maybe they got a diabetic foot ulcer and got an infection, and to prevent, gangrene, osteomyelitis, their toes need to be amputated. And you notice another thing with this picture is that the person has a cast on, okay, a total contact cast. And what this total contact cast does to the diabetic patient is take all of the pressure from the bottom of the foot and moves it up the length of the cast. So it's really exceptionally good at offloading pressure. And this is really the gold standard of care for diabetic neuropathy offloading of foot pressure, is this total contact cast. We don't see a whole lot of it here in Northwest Indiana, but it is considered the gold standard. All right, so we already covered a lot of these things already. One thing that I just want to mention is to do daily foot care, okay, and make sure that we're doing daily foot checks, instructing the older adult to do those daily foot checks. Check things like for calluses, for ulcers, for cellulitis. Wash and dry the feet real well. Make sure the toenails are short. Put lotion on the feet to prevent cracking. Report any calluses to the physician or the podiatrist. Make sure that we do offload that foot. Fall precautions are very important with diabetic neuropathy because the older adults can't feel their feet. They don't know where they're stepping. They don't know what they're stepping on. People often describe it like they're walking on pillows or walking on stumps. They can't tell where their foot's landing. Okay, so at higher risk for falls. And then referrals are also very important. If the patient is an outpatient, usually we will go to or refer them to podiatry. If they have a large ulcer, if it goes to the bone, or they have a large foot deformity, they will need to follow up with their orthopedist. And that is it for the endocrine lecture. I hope you have a wonderful day.